So obviously this is an area of great topical interest, and I was just going to highlight a little bit of the information of what we know about this and what we don't know as well. We've really been caught a little bit unaware with all of this, I would say. So to start with, just thinking about aerosols and droplets. So just to give you a little bit of background, I'm sure many people have been reading and had interest in this area, but the SARS-CoV-2 virus, which is the one that's causing the current pandemic, is a coronavirus, of which there are several families, and the coronavirus seems to be related to the SARS virus, the original, the one that caused the SARS epidemic in Asia and Southeast Asia in 2002 to 2003. Its exact origins, however, are uncertain. It has some sequence homology in terms of molecular structure to ones found in coronaviruses that are found in bats and in pangolins. And the question is whether there was a food market where pangolins were a meat within Wuhan in China, where this virus could have originated, but that's still a little unclear, but we think that's the probable source of this. It seems to be a variant of other coronaviruses, and coronaviruses naturally do live in animals, and in some animals they can cause gastrointestinal disturbance. Respiratory disturbance seems to be particularly a problem in humans. So there are other coronaviruses that are relatively harmless and just cause the common cold, but these ones obviously is causing much more severe disease. And we know that it's very similar to the SARS-CoV-1, the original SARS virus. It binds to a receptor, the human ACE2 receptor, which is distributed in certain tissues, particularly as I'll talk in respiratory epithelium. So here's in the top right here, you can see that there is a picture of this is a SARS-CoV-1 virus attacking respiratory epithelium. Here we have the virus, and this is a pneumocyte within the lung, and it's attaching and invading. So beyond, obviously it was originally spread from an animal to a human, and then it's obviously spread very rapidly between humans. And you don't need to see these graphs. I'm sure you've all seen how quickly it has developed as a true pandemic across the world. And we think there are three potential sources of spread. First being droplets, which Cath will talk about in more detail. But essentially there's droplets and aerosols, and there is a somewhat arbitrary breakpoint between droplets and aerosols in terms of size, which is 5 micrometers. So bigger than 5 micrometers is classified as a droplet, smaller than that is classified as an aerosol. And as well as that, there is something called fomites, which is basically substances that can carry the virus, such as tissues, surfaces and hands. So these are called fomites, where the virus can spread. And the relative importance of these three different mechanisms to spread is uncertain. Certainly we're confident that it can be spread within droplets. There's increasing evidence that it's also spread by aerosol, by small particles. And although it can be spread by fomites, it's unclear if that is a main route of spread as compared to droplets and aerosols. Certainly the rapid spread we have seen across the human population would seem unlikely to be spread predominantly by fomites, by contact with virus-carrying substances. So in terms of understanding exposure, I think this is the way that I've tried to conceptualize it. I think what we need to think about is the viral load in the source of the potential exposure. So that might be a particular tissue, or it might be a fomite where the virus is residing. And then there is an exposure event and duration. And in particular, within this, we're interested in aerosols, which Cath is going to talk to very soon. So it's both the event and how long that lasts. And that might mean, for example, working in a hospital environment with aerosols around for a prolonged period. And then obviously it's mitigated by protective practices or equipment. So that includes both the behavior and also what you're wearing. And I'll come on to talk about that later on. Then you get a virus exposure, and we still really don't understand all of this because we're trying to get information rapidly when none exists. But what we understand is that there are mucosal receptors. So as I mentioned, the ACE2 receptor where the virus will bind. And we understand now there's emerging evidence that there are variations in how much those receptors are expressed in different people's airways, which might mean that some people are more susceptible to ingress of the virus than others. We also understand there's, of course, mucosal immunity, and it may be that if you are exposed, your body just fights it off. There's systemic immunity, so if it extends beyond the mucosa into other tissues, your systemic immune system may well destroy it, or perversely may have an overreaction and cause more tissue damage, which is certainly some of the things that we're seeing. And then, of course, therapy can intervene on that, although the therapies we have to date are somewhat supportive rather than curative. So as I say, those factors interacting together will determine whether we get clearance of the virus, whether we get asymptomatic carriage, which we think is highly prevalent, but we're uncertain, mild or moderate infection, severe infection, or death. So what do we understand about viral load? Well, certainly in tissues, it is predominantly found, as you'd expect, in the respiratory tract, and that includes the oral cavity. So it's been demonstrated quite clearly in the oral cavity, the nasal cavity, the pharynx, the larynx, trachea, bronchus, and lung, which is, of course, the site of entry of aerosols and droplets, which are brought in, and that seems to be the main site where they reside, unless you get an overwhelming response where it probably infiltrates into other tissues. So the 2 points in red I wanted to highlight here is we know that it is high levels in oral and respiratory tract, particularly the nasal cavity has very high viral load, but it can also be present in asymptomatic or pre-symptomatic patients. So unlike some other viruses where the viral titer will continue to rise as you become unwell, actually you can have very high viral titers and be completely free of symptoms, or you can have very high viral titers before you start to develop any symptoms, which is why this seems to be spreading, of course, without in people that say they feel absolutely fine. There are some post-mortem studies which you have of severe cases of the SARS-CoV-1, that's the SARS epidemic that happened in 2002, 2003, and there you can find other tissues that have this. Intestinal mucosa, which is probably affected also by the SARS-CoV-2, because around 20 to 30% of patients with the current pandemic also complain of abdominal problems and diarrhea. But it's also been found in post-mortem studies in salivary ducts, parathyroid, pituitary, and brain, and other tissues as noted there. Now, these were severe cases, so it's unclear if actually mild cases would have the virus present in those tissues, but perhaps we have to assume that's potentially the case. Now, in terms of fomites, these surfaces that can also harbor virus, as I've mentioned, we're unclear what the viral load is on those, or indeed the importance of them. What we do know is that it can exist for some time on these various surfaces. So, for example, it can exist on cardboard, and here's some data that were recently published showing the survival of the virus on cardboard in terms of viral titer over sort of 24 hours, stainless steel for a little bit longer, and on plastic for almost 3 days. Now, these are high viral loads placed in a laboratory setting in perfect conditions for the virus to survive. So it may be that this is, unduly pessimistic view of how long this virus can survive, but nevertheless, it can exist on surfaces. There's also been evidence that it's found at reasonable levels in toilets within health facilities because of this intestinal infection that can also occur. It can be transmitted potentially by the fecal route. Again, we don't know the importance of fomites in spread. We certainly think that droplets and aerosols are highly relevant. So in terms of what we can find in droplets and aerosols, here's some data from seasonal coronavirus. That's your normal coronavirus that would just cause, a common cold. And these were some data measuring virus in patients who had an infection in their breath over 30 minutes in 17 patients. And you can see that there are reasonably high titers in the nasal swab and throat swab, but you can also find it in droplets, those greater than 5 micrometers, and also in aerosols, those smaller than 5 micrometers. So it certainly can find it. Now, again, in laboratory settings, what we find is that the aerosol can actually persist for quite some time. So for several hours, if you look at this is the aerosol over time. It's actually the red line you want to watch. This is actually data from the SARS-CoV-2 virus, and it can exist for some hours. So what we think is that the aerosol is being generated and is laden with viruses, and it can persist for some hours. Exactly how that relates to risk is not something that we're completely clear on. What we find is that the studies that have been done of sampling virus in hospital air samples actually find it's infrequent. So we don't know if we're just not sampling often enough, or whether these particular environments, which often had extraction mechanisms within for extracting air from the room, are actually getting rid of the aerosol, which may not be widely available. We also know, however, that from the SARS epidemic, health workers who wore a mask were much more protected, and that was the single biggest factor in protecting health workers, which again underlines the probable importance of droplets and aerosols as being a main mechanism of spread. We also understand that this is just from questionnaires of healthcare workers that developed SARS versus those who did not, that certain procedures, as you'd expect, tracheointubation and tracheostomy, do increase the risk of developing these coronavirus-associated disorders. So what we don't understand is how that aerosol is generated and where it spreads from a number of procedures such as airway examination or instrumentation. And that's work that we're trying to continue with. So here is a list that Public Health England have listed of aerosol generating procedures, which includes intubation, extubation, tracheostomy, as you'd imagine, and a variety of other procedures. This is from Public Health England. Other bodies have suggested other possibilities, such as oral and nasal examination may also generate aerosols, and have suggested full precaution when undertaking those. And I know the Royal College of Surgeons has also suggested laparoscopic surgery is a potential high risk. So we essentially don't know, and this is work that needs to continue. Here's an example of a simulated cough during potential intubation with a fluorescent dye that was recently published, and it shows these are obviously droplets, because you wouldn't be able to see if it was an aerosol being sprayed onto a mask. So this certainly exists, but how and to what extent, we're uncertain. So I think I'm going to hand over to Cath now and come back in a little bit.
So I'm going to talk a bit more about aerosols, how they form and where they go, and what that might mean in terms of the environmental control of them. First question of all is what do we mean by an aerosol? And if you look in the dictionary, you'll get these two definitions. You'll see that an aerosol is a suspension of a fine solid or liquid particles, liquid droplets in a gas, whereas a droplet is a very small drop of liquid. And that's not a very helpful definition. And what you'll find is that depending on which field you're in, whether you're in climate science or whether you're in airborne infection, you'll actually get these terms used very, very differently. What I think is really important is to think about size. So here's a 100 micron droplet. That would definitely be called a droplet. And it's a bit bigger than your average human hair. Typically, human hair is around 60 micron in diameter. It varies a bit, but that's a fairly typical size. Here's a 10 micron particle, aerosol, droplet. And these are commonly called droplets, okay? But now you can start to see just how small that is, particularly compared to the size of the hair. You're not going to be able to see it. And here's a 1 micron droplet. So the 10 micron droplet, the 1 micron droplet can carry microorganisms. In fact, so can the 100 micron droplet. They can all carry microorganisms, but their behaviour will very much depend on their size and the environment that they're released into. And I think it's really important to have that awareness of size. So what size matters then? Okay, so we refer to, in infection control, tend to refer to particles that are less than 5 micron in diameter as airborne, and those will be the ones which can be inhaled all the way to the deep lung. However, if you do look at the graph on the right, you see we have this curve called the respirable convention. These are essentially the particles that are statistically able to get down into your deep lung. And you can see that although it's a small chance, statistically you can get particles down to up to 10 microns, which will make it all the way to the deep lung. You then have anything that's above about 5 microns is called a droplet and is said to fall out of the air very quickly. The reality of it is that is not the case. It will stay airborne for quite a long time. And what you can see from the graph here is that we have what we call a thoracic convention. These are the particles that will get into the, I suppose, I'm not a clinician, but the top part of your lungs, so into the upper part of your chest. And that will, again, down to about 20 microns, we'll get there. And then we have what you call the inhalable convention. You can inhale particles easily up to 100 microns in diameter, but most of those much bigger ones would impact out on in the your nose and your throat, the top of your respiratory tract. And it's well worth mentioning that you can't see anything that's smaller than about 40 microns unless you've got really super good eyesight. So understanding what these particles are is pretty much all the ones we're really interested in are invisible to us, and you need to bear that in mind. And I think it's also important, particularly for this current disease, that we do need to consider the whole range. We don't yet know what size particles people are aerosolizing with this disease. We don't know which size particles are the most risky for disease, whether it's the impaction onto surfaces, or the inhalation and impaction into the upper respiratory tract, or even deposition onto the eyes and nose. So I think it's really important that we understand all the different sizes in here. How do we actually generate an aerosol? It's really, really complicated, and you get aerosols everywhere. So you get aerosols that are created by the fluid moving. So a splash or a bubble burster is an aerosol that's generated by the fluid. If you look around your home, look in nature, you'll find aerosols generated by taps and showers, by fountains, waves at the beach, the raindrops and things. In a more biological setting, urination, diarrhea, vomit are all mechanisms for releasing aerosols into an environment that might be relevant in healthcare setting. And then of course, when you start doing surgical or treatment type options, anything which uses water or some form of water line as part of the treatment can potentially involve an aerosol that's driven by the fluid. You then get another set of aerosols which are driven by the air, essentially where you've got a very fast airflow goes over a wet surface. It's thought that that's likely to be the case with the most respiratory aerosols from your breathing, from the behaviour of your vocal cords and things. We don't truly know though. There's a lot of uncertainty about how aerosols are actually generated in the human body. You also get aerosols in building systems, building ventilation and drainage systems, and I've noted drainage systems because that was one of the mechanisms in the 2003 SARS outbreak. And then of course, as Mahmood has already mentioned, aerosol generating procedures, which essentially involve some form of usually enhancement of the airflow or disturbance of those wetted surfaces in the human body and the nose and the throat. And that includes things like positive pressure ventilation, where you're actually actively encouraging an airflow into the lungs and therefore potentially increasing the rate of aerosol generation. And I just want to show you these. They're not really medical, but they're lovely videos, and just to show you the complexity of aerosol generation. So this first one is a splash. It's a very high speed, high resolution video. So imagine that this droplet might only be a few millimeters in size, but you can see it creates this lovely corona type effect where and then it releases the particles from the surface of it. So you can see actually the complexity of how aerosols are created is really challenging. And these are two different ones. Well, another different way of generating. These are like, imagine raindrops falling on the ground. Those are about 1 millimeter sized droplets. And as the droplet falls, it traps air. And then you get these little tiny air bubbles that essentially eject tiny aerosols out of that particle. And you've probably all experienced this one. If you take a glass of champagne or sparkling water or something and you hold it after you've just poured it, hold it very close to your face, you can feel the tiny droplets land on your face as they hit you. But I think this is just to show the complexity of it. The other interesting thing about this particular one is it shows that aerosolization is a surface effect. So when something is aerosolized, it's the very top surface of the liquid when its interaction with the air that's ejected out. And it is quite well known that some microorganisms can sit on that surface preferentially, they're hydrophobic, and may be more likely to be aerosolized. Going back to respiratory then, what do we know about respiratory aerosols? Well, we do know there's lots and lots of people have tried to measure this over the years. The data that's shown here is actually from 1946, but is still widely used because actually it's such good quality data. Most of this older data was measured by people coughing onto slides, and then they're put into a microscope and counted for different sizes. More recently, people have developed methods using optical particle counters and similar, and that does mean that we are starting to identify that the number of particles in the smaller size ranges, so below 5 micron is probably higher than in the graphs that are shown here. So what you can see from these graphs is that the numbers of particles generated depend on the activity. So you will get more particles generated when you sneeze compared to coughing, and then compared to, this one's somebody counting up to 100, so it's simply a talking type activity. There is also data that suggests that aerosol production is related to the loudness, so people who sing, maybe it's a greater level. And there is data now just from breathing, which shows that aerosol is generated just in breath. I've mentioned evaporation on there. This is quite an important part, and it's something to think about when you look at data that has been measured, because an aerosol, once it leaves the 100% humidity of the human mouth and enters a much lower environment, say your surgical environment or your hospital environment, it will evaporate very quickly. And so depending on the distance at which some people have measured from the mouth, they might give you slightly different size distributions because the evaporation plays a big part in that. So thinking about how do we actually sample for microorganisms, because all the data I've shown you so far is just particles, but actually what's really important is not the particles, it's what carries a virus with it. And not every particle will carry a virus. So how do you actually sample for microorganisms? This is really tricky. And there are two instruments shown on the slide. The guy on the left with his head in the cone, that's an instrument at the University of Maryland by Don Milton's group. It's known as the Gesundheit 2, which I believe is German for sneeze. And basically, he will have participants with disease sat in there with their head in that cone, breathing, coughing, talking, sometimes wearing a mask, sometimes not. And that instrument will sample virus particles into different size fractions, and it will separate them by above and below 5 micron. So we can identify what virus is in the 5 micron or the fine fraction of the aerosol. The other two pictures are something called a Cath sampler, so that stands for Cough Aerosol Sampling System, and this was designed by Kevin Finelli in the US, and this is for sampling TB patients. It's a much cruder device. It basically uses existing aerosol samplers inside a metal drum. Somebody will cough or breathe into a tube, and that will enable collection of that aerosol from somebody's exhaled breath. And you know, just to show how little we know about aerosols from microorganisms in cough aerosols, the cough sampling for TB was done in 2004 for the first time, and that's the first time anyone successfully sampled and cultured TB from a patient exhaled breath. Before that, we knew it was airborne. We've known it was airborne since the 1950s, but we didn't actually couldn't actually prove it directly through an exhaled breath sample. And then the data on influenza is from, I think we started in about 2009 there. And again, it's only in the past 10 years that we've been able to size fractionate that and really understand what's in people's exhaled breath. So you can kind of imagine that with the current disease, it's not surprising, we don't know yet, although I have a strong suspicion that Don Milton has got corona patients with their head in that cone as we speak. In terms of what we find, this is just two different sets of data. So on the left-hand side is data from cystic fibrosis patients. This was taken using the Cath sampler by a group in Australia. And what they've shown is they've sampled that they're looking for Pseudomonas, because Pseudomonas is a particular concern for people with cystic fibrosis. And they've shown that basically patients can aerosolize Pseudomonas. They sampled 13 patients here, and all of them aerosolized Pseudomonas in here. And some of them, you could easily detect it at quite significant concentrations up to 4 meters away. So that's really quite an important distinction, that it's not just that this is being aerosolized, it can survive over some distance. And this was done in a controlled study where they basically coughed into a big tube. An earlier study by the same group found that 70% of the viable aerosols were at less than 3.3 micron in diameter. So it's the small fraction that has the largest percentage of viable aerosols. And then the two graphs on the right hand side are data from Don Milton's group, and basically show this is viable influenza, under 3 circumstances, so with no cough, with a cough per minute, less than 1 cough per minute and more than 1 cough per minute patients. And what you can see here is that the number of viral copies in the sample, it's actually higher in the fine fraction than in the coarse fraction. So again, suggesting there's some perhaps preferential for aerosolization of this virus within the fine fraction. What happens then? Once you've got an aerosol in a room, where does it go? Okay, so an aerosol, think of it like a little ball. It has forces on it, so gravity tries to drag it down, but it has a drag force on it which is going to try and keep it buoyant in the air. And so if you release an aerosol in still air, it will settle on at a particular rate depending on its density and its volume or its mass. Okay. But it's not quite as simple as that, because actually air is not still in real environments, it moves, and the air velocities are quite significant and can easily keep particles buoyant for longer. So we need to take that into account. We also need to take into account the evaporation. And this one here is a model, this is a computer model showing what happens when you release particles of different sizes into air at a rate of 10 meters per second, that's similar to a cough, and how far they go. And what you can see is those really big probably pull out of the air because they've not got enough momentum. But once you put them in a real room, it changes very slightly. So the really big particles are still ballistic, they go a big distance. The particles of sort of 100 to 200 microns, they really falls out the air. But the 10 micron particle now remains in the air because the air velocity in the room is sufficient to overcome that gravitational force. So it's really important that we don't forget the air movement, and that's not just ventilation flows, it's also things like the movements we induce when we walk around, when you open a door and you have a window opened, etc. We will induce lots of flows in the room which can keep particles buoyant. I mentioned evaporation as well, and this is quite a nice study from 2007, which is again a modelling based study, but basically calculated that any particle that has an initial diameter of about 125 microns or below is going to evaporate, and will evaporate quite rapidly to the point that it will probably remain in the air as a 10 micron particle or less, and therefore potentially carry virus. So it's really important that that gets considered in it as well. The evaporation will depend on the humidity of the particular environment that you're in. So we have to think about when we're looking at how do we design a building, how do we ventilate a building, we have to think about 2 factors, the proximity to something and the airflow. So this is a computational model. It's not of a real environment. This is actually of a pseudo environment. But the thing in the middle is what's called a din man, and it represents the heat source from a person because we're all warm compared to the environment that we're in, and is releasing a contaminant. We could call it a viral aerosol. What you can see is that the colours show the concentration. So you get much, much higher concentration at the source, but then it's also released into like a plume, and you retain some of that high concentration as it rises up ahead of where that person might be. Eventually it mixes around, so this is like a slice through the middle of a room, and then it mixes around and gets some more uniform colours in the middle of the room. The second case is a very different, it's the same room but with a different ventilation system, and what you see is very close to the source you still get this high concentration with the plume, but you get a different pattern in the rest of the room. So we have to think about both together. We have to think about how the ventilation is designed in the room, and we have to think about the source and the proximity to the source. And certainly in ENT, you're going to be very close to the source a lot of the time, so thinking about that source protection is going to be really important. So from an engineering perspective, because that's where I normally come from, we are looking at how you can control transmission. And the primary route to controlling airborne transmission is a ventilation. So a higher ventilation rate dilutes the air quicker. The different distribution of air changes how those particles are moved around the space. We use pressure, so we'll use negative pressure environments like an isolation room to stop air moving between two spaces. An operating theatre is under positive pressure, so air moves from the clean space of the operating theatre to the dirtier spaces of the corridors, whereas an isolation room, it's the other way around. The room itself is the dirty room. We can use technologies as well, so filtration, air cleaning technologies, decontamination technologies, and engineering can also prompt what you do, so having smart buildings in there, limit access to certain places, etc. From a ventilation point of view, I think a lot of what you will do in terms of aerosol generating procedures are likely to be in operating theatres. So they have a very high ventilation rate, it's typically 25 air changes per hour for a high dilution. And those are tested, they're commissioned, and I think they're tested once a year to check that you have high velocities around the patient zone. There are typically two different types of theatre. So a conventional theatre is ventilated very like any other room, just at a higher rate. But then some of you may use ultra clean theatres, or which are sometimes known as laminar flow theatres, and they will have a central unit in the theatre which provides a much higher clean zone. So it has a downward flow in that clean zone, and it has some recirculating flow with filters in it to provide a much cleaner space, particularly for orthopaedic surgery. So if you look around a hospital most generally, your operating theatre is probably one of the safest environments to be in a hospital, but they are under positive pressure. That assumes that the patient is the highest risk, but actually if you've got staff in the corridor outside, the air from the room often goes to the corridor, so there is a potential risk there. There is issues in that the actions of what people do in the operating theatre can block the airflows as they're designed. So if you imagine you've got this ultra clean theatre with a really nice downward flow, if you're working over a patient, you stick your head in it, you block that flow and you create recirculations and things. So it's never going to be perfect. There's also an issue with equipment in that many theatres were designed many years ago, and we've put more and more equipment into them. That creates heat, that messes up airflows and things, and it can bring its own contamination. So there was cases a couple of years ago of heater cooler units, which I think are used in cardiac surgery, causing significant disease outbreaks amongst patients in theatres. And there was a particular bacteria called Microbial tumori, which was causing infections in patients, and it was a worldwide problem. I'll show you some images of theatre flows. So this is a technique that's similar to the previous slides, which also had these colour pictures on them. Technique's called computational fluid dynamics, and allows us to model the airflow in the space, and just shows the difference between these two theatres. About 1.8 meters from the floor, so about breathing height for a surgeon. You can see it's a reasonably uniform velocity in there, so it's got a fairly high rate across the centre of the zone. But the ultra clean theatre on the right hand side with this central canopy is a much higher flow rate in there. And we can use these models to look at where particles go. So this is just looking at if something's released from a patient, where would they be taken by the ventilation, and then you can think about how that relates to proximity of people in there. Just to finish up then, some of the procedures will be done in other areas. So intensive care units, isolation rooms should all have controlled ventilation systems, mechanical systems, typically around 10 air changes an hour. Wards are often much more variable, so even side rooms might be naturally ventilated. The guidance, which is on the right hand side, suggests it should be at 6 air changes per hour, but actually much older hospitals will have rooms where the ventilation is lower than that, and where it relies entirely on natural ventilation, can be opening the windows, for example, can be really challenging. And just to say, how long is it till it's safe in a room? So this is a simple model which looks at if you generate an aerosol, say an aerosol generating procedure in a particular room, how long before the air has actually cleared that. So we assumed in this model we've got a 5-minute aerosol generating procedure. It starts at 5 minutes into the whole of the simulation. And we're releasing 100 particles a second. We don't know how much they really release, so it's a bit of an arbitrary number. and looked at 3 different cases. So the operating room is at 25 air changes an hour, the isolation room is at 10 air changes an hour, and the side room is the poorest ventilated at 6 air changes an hour. And we also assumed the worst case scenario. So we assumed all of these particles stay in the air, nothing deposits out on the surface. And what you can see is that the first of the red lines shows that that's when your procedure has finished. So that's the highest concentration that you have in the room. And as soon as the basically as the procedure starts, the aerosol builds up in the room to a particular rate, concentration. That concentration depends on the ventilation rate. Once you stop generating your aerosol, it dies down again. If you're in a well-ventilated operating theatre at a full 25 air changes an hour, the chances are you're pretty much down to background again in about 10 minutes. If you're in an isolation room, 20 minutes. If you're in a side room, you might want to wait a little bit longer because it's probably a little bit riskier in there. I think my advice would be to do your aerosol generating procedures in well-ventilated spaces as best you can. And that brings me to the end of mine. I think I'm going to hand back to Mahmood now.
Okay, so to finish off, I mean, essentially, I think it's quite clear that we are uncertain about a lot of these parameters, and this is going to be work that we're going to find out some of the answers after the event. So just thinking about what we can do, I mean, go back to this idea of the viral load, the exposure event and duration, and protective practice or equipment. So in terms of that, we can reduce the viral load in the source. So that only really applies to fomites, so these sort of surfaces and so on, and we can clean those obviously with disinfectants. And there's now evidence from last week that, as you'd expect, the coronavirus does die with things like bleach, chlorhexidine, and betadine. It is killed also by soap, but less effectively than some of the hospital disinfectants. We can reduce the exposure events, and this is what ENT UK and others have advised, which is to avoid all but essential procedures. We also should look at reducing working hours in high-risk areas, and so hopefully many centres are now working on shift systems where people are not coming to work as often because you just won't expose yourself as often. Source isolation is another way. So those who are obviously infected, keep them separated from the rest of the ward. And then we talk about protective practice or equipment. I won't go over ventilation because Cath has already talked about that. And I think potentially in the next few years, we'll be rethinking quite a lot about how we design healthcare facilities with negative and positive pressures. I'll talk a bit about barriers now, and the barriers are obviously at source. So that can be to try and stop virus coming out in aerosols or droplets from the patient, and also barriers to the health workers. So that'd be things like masks. But also, and I'm not going to go into this in detail, we know clearly as well there are important factors related to workplace behaviours and cultures. So it's just being protocoled and driven to make sure you follow your donning and doffing procedures, because there's evidence that if you don't do that, you will put yourself potentially at higher risk. So, patient wearing a mask, just briefly, we do know that if you wear a mask, it reduces the amount of aerosol that is, and droplets that are propagated forwards. So these are some data from a paper which show that if you wear a surgical mask, actually the aerosols are still there, but they're propagated to the side or behind you. And the same with an N95 mask, some are still coming out. So it's not that it stops them coming out, it just redirects them so they're not coming into your face, which is probably a good thing. Obviously, we don't know in ENT why we are particularly at risk. Is it a combination of both that we do aerosol generating procedures, but also because we get so close to patients, because even if they're breathing and speaking, we'll be exposed somewhat. So in terms of protection, we know all these things. Masks, I'm going to come to talk about. You can also have these hoods, which I'm sure many of you have seen, which is powered air purifying respirators, visors to protect your eyes, an apron and gloves, which are basically to prevent fomite spread. And so I'm going to quickly talk about these masks to try and finish off. So the masks, I think you can divide into 2 different types of fit, which is a surgical mask, which just fits over. And that does provide some protection, but not as much as a respirator mask, which is a close fit, and obviously then creates an airtight seal. And I'm sure many of you are aware of the qualitative test of that seal through this fit testing, where you wear a hood and then say whether you can taste a bitter or sweet substance to check that the seal is indeed airtight, because if it's not airtight, then it's not aerosol proof, that's for sure. And in terms of the mask, there are different filters and there are different standards. There are the FFP1, 2 and 3, which are European standards, and those relate to the filtering capacity really of the material. And then FFP1 is classified as greater than 80%, which in healthcare settings is thought to be not acceptable. So we tend to use FFP2 or FFP3, which in the US have equivalent names of N95 and N99, which filter out either 94 or 99%. We tend to be using FFP3, but actually an FFP2 is actually pretty good and probably sufficient for most settings. There are some systematic reviews which suggest an up to 80% risk reduction in acquisition of SARS during the epidemic in 2002 and 2003 amongst health workers who are wearing these sorts of masks. But it's not clear that one type of filter is definitely better than the other. It's just using common sense most of the time. Just to make you aware that the FFP3 masks as well, they're often made of fibers which have these tiny little electrical charges on them, and these electrical charges help to repel viruses. The pores are not so small that everything doesn't get through, but the electrical charges do help to keep those particles away. And here on the right here we have a graph. This is the sort of particles that are coming in, aerosol penetration. This black line is an N95 mask, but if you actually treat it with a chemical that destroys some of the electrolytes, you can see its penetration goes very high. So it's important also to make sure the masks do not get wet. You can't wash them. That's certainly not recommended at this juncture. Finally, I'll end with these powered hoods, which some of you will be wearing. I know we certainly are using them to operate. And the idea there is you're actually delivering positive pressure to the wearer. So filtered air is coming through, blowing any aerosol droplets away from your face, and so providing positive pressure to you. Again, that just seems quite a sensible way to try and protect yourself. Also, obviously, then provides you with a visor, which will protect you from those, ballistic coughs and so on and so forth. There are a number of new opportunities for potential risk reduction. Some of you may be aware of this plastic box that's been invented for intubation using a video laryngoscope. There's also Hamid Dyer in St George's, who's created this tube for performing tracheostomy, and several people have come up with this snorkel mask, potentially fitted with a filter to it, which may also help to reduce. We actually don't know, and Cath and I and a few others are doing some work on aerosol generation and also aerosol protection and potential extraction through these devices. What's unclear is perhaps you could just trap the aerosol inside these boxes, and perhaps you could trap aerosol inside a mask as well. So we need some further investigation, and that work's actually going on right now. So I suggest you keep up to date. I'm sure you're all aware of the Inti UK website, which has updated guidance, and happy to take any questions.
There's a question for Cath, and that's really about, is there evidence for airborne transmission of aerosols, so distant transmission in the atmosphere?
I assume I mean long distance transmission. Yeah. No, there's very little evidence for any disease of long distance transmission. There is nearly all airborne disease transmission evidence is in indoor environments, and usually quite highly occupied indoor environments or poorly ventilated indoor environments. So there's very little evidence of transmission in outdoor environments. The only exception I say to that is there are environmental cases. So, for example, Legionnaire's disease from cooling towers. And there was a case in the SARS outbreak of an aerosol from a building sewage system, but those are environmental sources. There's no evidence of long distance from respiratory aerosols.
Great. So just to introduce myself briefly, my name is Chantal Rosanne. I'm an ENT research fellow at Brighton, Sussex University Hospitals NHS Trust, and I'll be helping to organise these sessions. We've got another question that's come in now from Ali, who says optical particle counters. This is a question to Cath again, but the optical particle counters are routinely used to test clean rooms and theatres in hospital. What are the pros and cons of borrowing those to test barrier protection, so things like shields and masks? And secondly, is there a lower limit where the size isn't likely to be relevant, and suggests maybe less than 1 micron, for example?
Okay. I'll do the second question first. So the size that's not likely to be relevant will depend on the size of the pathogen. So coronavirus is a very small pathogen. It's about 100 nanometers. So theoretically, it could exist in aerosol particles down to 0.1 micron, so 100 nanometer aerosols, theoretically. It is probably unlikely that it will, because normally when they're released in obviously in the respiratory fluids, which contain proteins and salts and other things, and those are often as big as the virus themselves. So when it evaporates to its smallest amount, it's still going to carry some of those proteins and things with it. So may not be down to that, but that's about the smallest that you're likely to go. Below that is unlikely to be anything carrying virus particles. In terms of borrowing OPCs, yeah, you could borrow OPCs to look at masks and things like that. The real challenge with measuring respiratory generated particles is being able to know that you're measuring them accurately and accounting for all the environmental factors that are going to influence it. So many of the studies that I've shown you are carried out in very controlled conditions, where basically somebody's designed some sort of an instrument where people will stick their head in it, and it is taking those aerosols and only those aerosols and that air away from the person, and will also be in a HEPA filter in it to prevent any background particles being in there, because a lot of environments have a lot of background particles. If you to go and measure in an operating theatre, or go and measure with a mask or something, you might see something, but you might find there's a lot of noise. It might be quite difficult to actually identify it unless you really know what you're looking for. So it's hard to say that that's going to be a beneficial thing to do. Although, having said that, if you go and borrow the OPCs, you can you certainly get a good feel for what types of things generate aerosols, and it gives you a better understanding of what's going on, even if it's not truly scientific.
Thank you, Cath. So I've got a question for Mahmood from Rob Grounds, and this is specifically about there's been some, I think, a publication about using dilute betadine up people's noses and doing mouth rinses. And what's your opinion about the evidence for this, and whether we should be doing this before ENT procedures?
I saw that paper had been published, actually, but I haven't had a chance to read through it. I didn't know if it was an opinion piece or they'd actually shown that the virus has gone. As far as I'm aware, they haven't shown that the virus is gone. It's probably, I don't know, I guess it's probably not going to do any harm, but I wouldn't sort of suggest, of course, that you use that in lieu of appropriate mask protection. And I think most of us would suggest that as long as you're wearing an appropriate mask at an appropriate time and you're diligent with that, the chance of you getting anything is actually so significantly reduced. If you're wearing an FFP3 mask, which is appropriately fitted and is filtering out 99% of everything you're breathing in, I'm not sure that, you know, rinsing out with betadine is going to help that much more, but, you know, I wouldn't say we know the answer for sure.
Okay. And really, just a follow-on question from that, there's a question from Kieran, and he's asked for some clarification about powered respiratory hoods and tracheostomies. So apparently there's a theory that they pump air in rather than out, in which case is actually an FFP3 mask better?
They do pump air in, so it's providing positive pressure to push air away from the face. But the air that they're pulling in is obviously the filtered air from behind. So the potential advantage of that is, the air is filtered, although perhaps it's not been, as far as I'm aware, these masks have not been assessed for viral particles. But the air is obviously not directly in front. It's from behind, because you wear the pack where the air is coming in is from behind. So that would, you know, you would imagine that that's got less aerosol and droplets in it. So the idea is it's pushing things away. The debate about FFP3 versus powered hoods continues. I think one of the problems, this is anecdotal, that I've heard from some surgeons who are using the FFP3 mask, is that it's very difficult to do an operation and make sure that that maintains an airtight seal. If you're doing a tracheostomy for 30, 40 minutes, it may take even longer than that with all the new procedures we have to do. It's very difficult to be sure that that FFP3 mask is completely airtight for the whole duration. So again, I don't think there's clear answers, but our department has certainly opted for the powered hoods in preference.
And we've got a follow-on question from Darren Yap in relation to that. He's asked, actually, is there any virtue of using the FFP3 mask in conjunction with the hoods?
I don't know that we haven't got any data on that. Potentially, I guess so, but maybe Cath may be better able to sort of talk about the dynamics of that. That's just my concern, whether the positive pressure may actually lift the mask off and actually trap virus inside. I don't know. Cath, I don't know if you have any thoughts on that.
I wouldn't have thought it would affect it. I mean, in a sense, yeah, it could be a double whammy of protection, but I wouldn't have thought you'd need twice the protection. I think you'd just find you were very hot and uncomfortable underneath an air hood with a mask on as well. So I think I would say one or the other. Just go back to Mahmood's first point about the air hoods, is that, yeah, they will be filtered, and I don't know what grade of filter it is, but I'm pretty sure it's a HEPA filter, which will go down to those the virus sized particles, because they just wouldn't bother selling them otherwise.
Got a question from George McClellis, and that's about the risk of blood droplets transmitting the virus, especially in respect to neck procedures, for example, a neck dissection.
So the question is whether the virus is even present. And I think the problem is, how do you know that? Well, we do know it from patients who are very sick with the SARS-CoV-1. So the original SARS epidemic, it was found within the blood. It seems unlikely that if you are not systemically well, you will have significant viral particles, as in a viremia, if you're not that unwell. Obviously, we have this grade of disease. I think a lot of us can carry it asymptomatically or very, very minor symptoms within the respiratory system. It seems less likely that that would be present within the blood in significant amounts and you'd still be feeling well. This is all theoretical, but that's what I would imagine.
I think we probably have time for one last question. Chantal, is there anything?
Yeah, a question here from Shanine, who works at James Paget, and is asking if they're undertaking aerosol generating procedures in clinic rooms where there aren't any airflow systems and they're relying on other, ventilation via windows and so on. Should they then be leaving the room for, say, 3 hours after the procedure?
Oh, that's really hard to say, because it will depend totally on the environment. I would always say try and ventilate it as best you can, as well as you can. It's what I would do is, if you are using those rooms, I get onto your hospital estates team, ask them to come and look at the ventilation in those rooms, to set it up as best they can. If there are rooms where you have to perform these procedures and they really are poorly ventilated and there's nothing else you can do, you could get local air cleaning devices. So there are these sort of UV devices or HEPA filtered devices which basically pull air through and stand in the room and circulate the air through to clean the air. So something like that might be worth doing, because I think there's that trade-off between what is practical to do and what is the safest thing to do, and you've got to balance those, and I think making sure that you've got the best PPE you can in those environments as well. But ventilating as best you can in all the rooms is a really good idea. But get your estates team involved in that, because there is some risk in some naturally ventilated environments. Once you open the windows, you get flows between rooms which you weren't expecting and things like that. So it's not a straightforward thing.
Sorry, Cath, if I can ask you, in a poorly ventilated room where you can't improve things, we've certainly been going to suggest, well, we do open the windows, but 20 to 30 minutes, is that reasonable?
Yeah, typically 20 to 30 minutes is reasonable if you've opened the windows. But it just really depends, because some rooms will ventilate really well in that time, others won't. It's really hard to say, but I think estates, and I think lobby your estates teams, lobby your hospital administration, because if they're asking you to do procedures on infected patients in really poorly ventilated rooms, then that's just putting everybody at risk. Not just, you're probably the one at the least risk because you've got the FFP3. It's the people in the corridor who maybe just have a surgical mask who are going to be at the most risk at that point. And it's thinking about trying to manage that in those spaces better or as best you can.
Great. Okay, well, thank you, Mahmood and Cath. That was, like I say, it was fascinating talking. I think there's some action points for all of us to take forward, actually.